Forget about me.
I didn't forget about you. We just had a few things going on in the OR.
I guess I heard you was in surgery.
Yeah, I was in surgery and then there was something that came up and so another team asked me to come by and take a look at something.
Okay.
Okay, so the MRI that we just did.
Yes.
The good news from that is all your speech, memory, looks like it's on the other side. So
They didn't have me really talk.
they didn't.
No, she kept telling me don't talk, because that's gonna give us a different,
Okay.
pattern,
Uh-huh.
or fire off different.
Okay.
So the test was like, here's a letter A. Think of words that start with the letter B, A.
Okay.
And then another one was a letter B. And think of words that start with the letter B. And then another one was like a sentence that was unfinished.
Mhm.
Baby cats are,
Okay.
and then I had to think kittens, and so, but she didn't want me to talk the whole time.
Speech understanding will be on the same side as speech production.
Okay,
So that's okay.
okay,
Yeah, the arcuate fasciculus is the name of the fiber tracts, if you wanted to look it up. But what they were looking for was Wernicke's area, which is speech understanding, and it's located down in the temporal lobe on the left side.
okay,
And it connects to Broca's area, which is up in the frontal lobe on the left side. So
okay.
it just kind of looks like a C set of fibers. But
But we're staying away from the left side, right?
right, we're on the right side. Now, like I said, percepts, understanding of certain concepts that may be affected with where we're gonna be. We can't tell that by looking at the MRI, the functional MRI. The main thing is memory and speech, and those are the things we wanted to make sure we
Weren't
definitely.
gonna mess with.
Right.
Okay,
So,
So
maybe
where's the tumor at? On
on
what side?
the right side,
right,
In
frontal
the-
lobe,
temporal.
temporal,
It's pushing up on the frontal lobe and pushing the frontal lobe over. So, but it's,
So it's kind of right in front of her ear, right here, on
Correct.
the other side from this, okay.
and it's actually, yeah, it's kind of deep in. So I'm actually going to do what's called an anterior temporal lobectomy. I'm gonna take the temporal lobe down, everything in front, come into the tumor from underneath. So we know that we're gonna cut the visual field. And the question, if we go too far back, we affect a larger portion of the visual field. But we could also be damaging some understanding of certain concepts or emotional ability, anxiety, mood issues.
anxiety could be gone, I'll be happy with that. I really hadn't dealt with any anxiety
Mhm.
until probably the last couple of months.
Okay.
And I'm like, whoa, it was something wholly new to me.
Well, the area, we could be looking at damage going either direction. But, we won't actually know until after. There's no need to do the surgery awake,
Good.
because there's nothing that we can.
I didn't want the stress.
And even with surgery awake, I've had probably 2 out of maybe 30 patients that I've done the surgery awake. Even with doing that, we still ended up causing an injury. And so it's never a foolproof thing. But in this case, there's nothing that we could detect that would be helpful with you being awake.
Okay.
So, all right.
Works for me.
Any questions?
Put my
Did it
ass
grow
to
it, did it
sleep.
grow at all?
Um,
Did it measure?
We didn't give contrast for this to look for that.
Okay, I was just wondering
Yeah, they didn't
how
do
fast it was
contrast.
growing in there or what?
I
This
could-
was been, what, 4 days since the last one, so.
Right. We could try to look at that, but it'd be extremely difficult to tell.
Okay, I was just wondering.
All right.
I just want it out.
Well, Dr. Akbeek, who I've asked to join me once he's done with his surgeries, he's scheduled to be doing an operation during the time I start, and so he'll come in a little bit later. So,
And which one is he? Is he the oncologist?
He's a complex spine surgeon,
Oh, okay,
but we did tumors a lot together before,
okay,
and so it's always good to have two hands and somebody that you've always worked with.
yep,
So when your hands know what the other person is about to do, that's helpful.
yeah.
So,
A buddy,
Yep.
a coworker that
Yeah.
can finish your sentence.
right,
and-
exactly.
Yeah.
So that's the reason we work together a lot.
Cool.
But he's only my assistant in this case, so I'm your neurosurgeon. And so you actually only have one neurosurgeon for the case.
Okay,
Okay?
all right.
Any other questions?
How big is this incision then? Is it just a smaller one?
It's probably going to be about a C-shaped, something like this, maybe cutting a little further back. I'll have to see what is the best trajectory to get to the tumor,
Okay.
because I may have to cut it from behind like this. The blood supply comes from the front here and branches off kind of like that. And so damage to that blood supply will cause this muscle to atrophy. So we try to avoid that. Plus the scalp also will lose blood supply, and that could cause some healing issues or potential infections. So you also have another set of blood supply coming in from behind the ear. So we want to preserve at least one of those coming up into the scalp.
Okay,
So we'll look at that. We'll look at what angle we can get into the tumor or get into the temporal lobe safely. And then one of the things that I'll be looking for, I may end up, more than likely, I'll just end up making a large opening into the bone to be able to get the angle I need. So when I see the tumor, the edge of the tumor, I'll try to take out as much as I can.
post-op, will I have to have some sort of
Helmet?
helmet or protection or anything?
No, usually what I do is I'll either take the bone and I'll put a few pieces of small titanium plates. They we call them dog bones because they kind of have the shape of a dog bone.
Mm-hmm,
And I'll use those to hold the bone in place, and then a lot of times I put bone cement around the edges to make it smooth.
okay,
Because it's hiding underneath the temporalis muscle, that muscle helps you. When you bite down, you can kind of feel it pulling up here. That muscle, because that's over the top of it, a lot of times you don't have any issues with feeling the plates or anything underneath.
okay,
But sometimes, a lot of times I still put bone cement in just to make sure to seal it off anyway.
okay. You don't want no leakage.
Definitely not. So in total, the incision is usually about 4 inches or
Asher's got
5 inches
a
maybe.
couple of his
Is she getting a
incisions are,
haircut then too?
I usually just do a strip shave, kind of a thin strip right along where I'm gonna cut the skin.
okay,
Just so that way when I pull it together cosmetically, it'll look better. And you'll have hair to hide some of it. The skin edges will be kind of buttressed up. And the reason I do that is so that the inside will hold together and eventually basically break down. Your body will absorb it over time.
absorb it, yeah,
But the incision line across the top will heal first. And so the scar will stay thin. You'll still be able to grow hair in that area, those kind of things. And that's the reason that I buttress it all the way. So a lot of people think that it's swelling, but it's actually just because I have sutures on the inside that are holding it together.
okay. Okay. Hold it together. Okay. I'm not real worried. You seem pretty confident.
Yeah. Very educated, I appreciate that.
Thank you.
Poking around in things.
One question that one of my siblings had that isn't here was how you know what kind of cancer it is if you haven't done a biopsy. Is that based on the images?
Based on the images, yeah. So like I was saying before about, I told a few others that if a tumor comes from somewhere else in the body, a lot of times it'll come up through the bloodstream. That's typically where it comes up through. goes into a capillary where it lodges, and then it grows from there, so a lot of times it looks very spherical. This one is not quite spherical, it looks like it goes along the track of the fibers, which is what primary brain tumors do. The neurons themselves, they don't regrow, they don't divide, but the supporting cells do. So astrocytes, oligodendrocytes, things like that, they will continue to grow. So those can become tumors. And they
Which
keep
is why
growing.
we're gonna do radiation and chemo both.
That's right. And so the way it grows is more of an elongated fashion in this case. It if something is outstripping its blood supply, so like tumors that come from the covering of the brain, they don't really outstrip its blood supply, they grow slow, so they appear more homogeneous in its appearance, they appear solid on the scans. Whereas this tumor is growing fast, so the center of the tumor is losing blood supply as it grows because it's growing too fast.
Gotcha.
And so you end up with these necrotic areas throughout the tumor, so it's what we call heterogeneous appearance. So those kind of things point towards
Gotcha.
this is primary brain.
So how long do you think she's had it? If it's growing fast?
A lot of times patients will tell me that the symptoms are anywhere from about 1 to 2 months, sometimes 3 months. So maybe about 3 months or 4 months.
Do you think it's growing that fast in that small amount of time?
I think it is.
You don't think it was there before that?
Usually
Like
not.
maybe
It's
like-
possible that you could have had a low-grade tumor that changed into a higher
Yeah.
grade, and you've had it all your life that it converted. Those kind of tumors, though, we'll find out once we do the genetics.
Okay.
Unfortunately, though, that's not very common.
I don't know, cause like, you know, like there's sometimes that those tumors are in there and they don't bother them at all until it starts growing, so like,
Mhm.
with her,
Yeah.
like it was probably small at one time, and then she got in that accident and she kinda started acting off anyways, so I don't know if it just started growing really big in the last 2 or 3 months, and then, you know what I mean, like, cause she wasn't acting off for a while, and then all of a sudden, obviously, it's pushing against things, so it's making her act a little different. So like her balance and then just her memory sometimes.
Yeah.
So I wasn't sure, you're not gonna go in there and be like, oh yeah, it's been growing for 3 months, you know what I mean, like,
Yeah. So, if you look at very large meningiomas, so those can be growing for years, decades, but they're so slow growing that the brain will push out of the way, and they'll get fairly sizable, maybe 6 centimeters, 5 or 6 centimeters before you really start to have a lot of swelling on the brain, and that kind of tells you the rate at which it's growing. In this case, we do see inflammation on the brain, but that could be just because it's growing aberrantly. But also the rate of change is kind of like being punched on the shoulder and it starts to swell. You have swelling on the brain, and so the brain is being irritated by something, and it's probably the rate of growth of this.
Okay.
And then you start seeing symptoms.
Huh?
And then you start seeing symptoms.
especially because it's pushing her frontal lobe, and that's a big part of your brain.
Now, even though the majority of memory is all that we see on the scans is on the left side, we can still have some memory effects from the right too.
Okay.
So you're still pretty much hoping tomorrow to get hopefully about 90% of it? Is
That's
that,
what I would like to have, because that's the amount that we can take of what we see is a determinant on the average change in survival. So the more I can take, the better it would be.
The longer
And
potential.
you attack the rest of it with chemo and radiation.
Yes.
Now, I have had cases where I've put in a dye and used fluorescence to kind of help me kind of augment the surgery. But the brain itself looks normal. If I encounter that area that looks normal, it becomes difficult to say where the edge is. And instead of potentially hurting you, I would more than likely stop if I started to see normal brain tissue.
Okay.
So, but we do know that the tumor grows through the normal brain. So,
Interesting.
Hopefully, we just
Anything
get the
else?
trap out and I get to go on and live some life and enjoy some grandbabies and some great grandbabies.
that would be the goal.
That's the goal.
Alright.
Some retirement
Now I'm gonna tell
and
you
enjoy
about
life.
I'm gonna tell you about a lot of risks tomorrow that sound pretty scary, unlikely to happen, but you know, the scariest thing is gonna be the risk of significant stroke. We are working on the brain, paralysis, paresthesias, decline in mentation or cognition, and worst case scenario is coma and or death. It's not a light surgery, it is a dangerous surgery.
Okay.
There's a lot of deficits that we are at risk for.
Okay.
What time's your surgery?
11.
11.
I've already got it on the prayer chain.
Thank you.
I kinda think we don't wanna think about any of the negatives, so. We've already had enough of that this whole week, so we, seem to we like you and we trust you, so just go in there and do what you can and try to fix her, please.
Absolutely.
And don't do no whoops. please.
Nope, that's the thing you never wanna hear from a surgeon.
No shit, yeah.
Especially a neurosurgeon.
Shit.
Do you have any idea what causes this type
Be
of
Hawkeye,
cancer?
not Frank.
Studies?
Up there with that would be a first.
There's a lot of studies on it, but unfortunately, as of right now, it's still a spontaneous event.
Yeah, it just kind of happens.
I personally think all the preservatives and all the crap in our foods now that I think that contributes.
I did feel that there was something odd about Omaha in general, because it felt like the frequency of seeing multi-site tumors was higher here. And that was just a little odd.
How long have you been here?
3 years.
3 years? And you've noticed that in 3 years? Wow.
So, yeah.
Where were you before?
Colorado and St. Louis, but St. Louis, I didn't really do a whole lot of neurosurgery there.
Gotcha.
I was doing a fellowship for nerve surgery there. So,
Braden's almost here.
What?
Braden is almost here.
One of my grandsons.
all right. Huge family.
Yeah.
You have any-
We're all concerned.
And this isn't all family, this
Yeah,
is friends.
We
too.
yeah.
This is a coworker.
No.
This is a good friend for
Long time.
a little over 30 years.
Over 40 years.
If you really got to,
Yeah.
if you really got to know our grandma, you'd
41,
understand.
41 years.
We're
41.
we're all
then-
invested.
Yeah.
Very nice.
Granddaughter, 2 sons, future daughter-in-law, a daughter, a granddaughter,
Great
a
grandson.
great grandson, and a, and a
Another son, Chris is right there.
Yeah.
son Chris,
And the other great grandsons out there.
other great grandsons out there, and their dad.
Oh, we don't know.
Yeah,
I think we're kind of.
Got a big family.
I see that.
You know, I had his, mine, and ours. So he's ours, he's his, and
The rest of us are hers.
these two are mine.
Married
She's
twice.
mine.
Ah,
Yeah,
okay.
married twice.
What?
Brady Bunch.
Oh.
Yeah.
There's one son that's missing.
Yeah, one son's in.
Well, I
Florida.
got one son in Florida.
It's usually where she's at.
I like to
She
visit
can't find her here,
Florida.
she's there.
I like to
Okay.
visit Florida.
Florida's
We're on a
nice.
cruise ship somewhere.
Yeah, I like cruises too.
Yeah.
Yeah, Yeah, so we need to get her on another cruise, so you
Oh,
need
yeah.
to make sure you fix her. Fix her good.
That's what we'll be working on.
Okay, yeah.
Alright.
She's very worldly. She's been to the Vatican and lots of
Very
places.
nice.
Yeah. Courtesy of my son being in the military, I've gone places to visit.
Okay,
So,
yeah.
the first time he was stationed in Italy,
Uh-huh.
we met in London. And we went to London for 4 days. And then we went to Rome for 4 days. And then he was stationed on the island of Sicily, so I was there for a while. And so, yeah, so when we were in
Yeah, absolutely.
London, we went to the Vatican, and
Very nice.
it was pretty cool.
Do these surgeries take quite a while then, or I suppose
It
it
will.
varies? Okay.
Yeah, it
About 5
typically
hours, did you
varies.
say?
5 hours was how much I said was the minimum amount of time.
Okay.
These are not ones that we wanna jump in and just start
Yeah.
damaging things.
Right.
We are gonna be doing that, but when we get to the posterior or the backside of it, we're gonna slow down a little and try to be more cautious because we could cause more significant damage in those areas.
Okay.
And towards the inside where your brainstem is, we wanna be extra cautious too.
I have a neighbor who, we've been neighbors for a long time, and she had an aneurysm. And then when they went in and was working on her, she had a stroke, and she's never been the same since. She's a totally different person.
That was the middle cerebral artery that I was talking about. That's, you have the internal carotid that comes up, and then the middle cerebral comes out. It's gonna be right next to where the tumor is. As the blood vessels go towards the back, the tumor that's pushing inwards towards the inside of the brain, those blood vessels are also very important.
That's what my sister Kathy that had my older sister Kathy had an aneurysm, and that's what happened to her. She had a stroke after surgery.
I don't want one of those.
He's trying, they're not gonna have
Do our best to avoid that.
to. That's not gonna happen.
Alright?
Good.
Alright. Okay, I will see you tomorrow.
All right.
Thank you.
Thank you.
Thanks, Alex. Appreciate
Yeah,
you, buddy.
thank you for the
Definitely.
information.
Yeah, definitely.
We'll see you in the morning.
Thank you
Okay.
so much.
Yep. Yeah.